And also just want to note that our recording today will be listed on YouTube. So we're going to have breakout rooms that are not recorded, that are a place to really like get into some things, share things if you'd like to. And then, in our main room here where we're recording is, I just want folks to be mindful of what you share. Make sure not to share anything personal about clients or about yourself that you don't want on a public video. Okay, so today's agenda, we're going to talk a little bit about trauma and its impacts, as well as trauma and homelessness. And then we'll get into what exactly trauma-informed care is and how to apply it to the work that y'all are doing, as well as how to apply trauma-informed care to organizations more broadly. So a little bit of a disclaimer, we are talking about trauma. It could be triggering, so please take care of yourself however you need to. Please engage as much as you can, use the chat, come off mute, ask questions. Today's training is for educational purposes only. So the information and support provided in this presentation and session is meant for educational purposes and should not be considered therapy. If you experience distress, please contact a mental health professional. And this is an introductory training. Learning how to apply these concepts usually requires much more in-depth multi-day training as well as follow-up and experience on the job. But today we're going to use the breakout rooms to help you apply the information as much as possible in our couple of hours together today. All right, so getting right into it. What is trauma? One way that we like to talk about trauma is with the 3 E's. So the 3 E's are event, experience, and effect. So an event or a circumstance can be traumatic for someone. An experience or how someone experiences an event or circumstance can be traumatic. So the way that they label or assign meaning to, or the way that someone is disrupted physically or psychologically by an event will determine whether it is experienced as traumatic. So an event that is traumatic for one person may not be traumatic for another person based on their experience of it. And then effect. Trauma usually has an adverse effect on a person. Those effects may not occur immediately, or they may be delayed, and the duration may be short or long term. So how do we define trauma? As alluded to in the last slide, individual trauma results from an event, a series of events, or a set of circumstances that is 2, experienced by an individual as physically or emotionally harmful or life-threatening, and that 3, has lasting adverse effects on the individual's functioning and physical, mental, emotional, social, and or spiritual well-being. Experiences that might be traumatic can include things like physical, sexual, or emotional abuse, childhood neglect, living with a family member with a mental health or substance use disorder, sudden or unexplained separation from a loved one, poverty, racism, discrimination, or oppression, violence in the community, and natural disasters are just a few examples. I want to talk a little bit about types of stress, though, because all these traumatic events are events listed on this slide that can be traumatic, are not the only way that someone can experience trauma and the effects of trauma. So first, there's positive stress. Positive stress is part of healthy development. It can include some excitement and nervousness. And positive stress is when we respond to a challenge or stressor well. It prompts our growth. So not all stress is bad stress. Then there's tolerable stress. And with tolerable stress, our stress hormones and responses are severe enough to change our brain architecture. It can result in difficulty eating or sleeping or fear-based thinking, but it can be worked through or overcome with coping skills and support. And then there's toxic stress. So toxic stress is basically tolerable stress that doesn't go away or that we don't have the coping skills or support needed to deal with. It's severe enough to change our brain architecture and is prolonged over time, and there are no protective factors to help it move out of the system. And this toxic stress has a very similar impact on the individual as trauma. So we just want to highlight this because when we talk about trauma and trauma-informed care, it's not just about an event that happened to somebody. It can also be someone experienced really toxic stress for a while, and that has an impact on them in the same way that trauma does. So just something to keep in mind. We also want to talk about adverse childhood experiences, also known as ACEs, because exposure to these experiences is pretty common across all sectors of society. 62% of US adults have at least one adverse childhood experience, and 25% of US adults have 3 or more. And research has shown that the risk for ACEs is particularly elevated within certain populations. And this is important because ACEs are another way that can contribute to trauma for someone, and that can have similar effects to trauma on someone. So when ACEs are sustained over a long period of time, they can lead to toxic stress. And as we just discussed, trauma can result from sustained periods of toxic stress over weeks, months, or even years, as opposed to resulting from just a traumatic event. Okay, any questions so far? We talked about what trauma is, the 3 E's of trauma, we talked about toxic stress, and we talked about ACEs. So if you have any questions so far, feel free to come off mute or put them in the chat. And we also have a Zoom poll wondering if you've ever encountered a client who you think has experienced trauma.
All right, I'm going to close the poll in just a couple more seconds. So hit submit if you haven't already. And then I will share the results so that everybody can see.
Okay, it looks like pretty much everyone here has encountered a client who has experienced trauma. So you're in the right place to be learning about trauma-informed care. And I'm glad that you're here today. Okay, so next we're going to talk about some of the risks or negative outcomes that are associated with trauma, ACEs, and toxic stress. So people who have experienced more ACEs or trauma or toxic stress are more likely to experience negative health outcomes and or engage in risky behaviors in each of these categories: physical, behavioral, emotional, cognitive, neurobiological, relational, and spiritual. And we're going to talk about a little bit of each of these a little bit more in depth. So first, let's talk about some of the physical and behavioral risks associated with trauma. Physical health and risk behaviors can include things like more likely to engage in substance use or unprotected sex, which can contribute to other negative health outcomes like adolescent pregnancy. And ACEs can also contribute directly to negative health outcomes through the impacts of chronic stress on the gut, for example. Some of the behavioral risks include self-harm, substance abuse again, gambling, self-destructive behaviors, isolation, things like that. So what is the relationship between trauma and these health risk behaviors? Some folks may develop coping mechanisms to help alleviate the emotional or physical pain they feel as a result of trauma, which is part of what can lead to some of these behaviors. That can include some risky behaviors as well as less risky behaviors. Like some folks experience trauma and they end up finding healthy coping mechanisms too. Risky coping mechanisms may provide some relief, but they can simultaneously contribute to anxiety, social isolation, and chronic diseases. Compared to folks with no ACEs, individuals with an ACE score of 4 or more were a lot more likely to do things like smoke, have STIs, be more likely to have chronic obstructive pulmonary disease, more likely to become an alcoholic, to have injected street drugs, or to have attempted suicide. And we just highlight some of these, and something that we're going to repeat throughout the presentation is to reframe our thinking from what's wrong with you to what happened to you. So sometimes we can see these behaviors in somebody and we think to ourselves like, gosh, they're so irresponsible. What are they doing? They're hurting themselves, not realizing that some of these are stemming from trauma that they may have experienced. So we really just want to reframe this from what's wrong with you to what happened to you, to understand their behaviors in the context of their life. So let's talk about some of the neurobiological, cognitive, and emotional risks associated with trauma. Neurobiologically, people can experience an overproduction of stress hormones that stay elevated when they've experienced trauma. So I don't know if you've ever heard of a book called Why Zebras Don't Get Ulcers, but it's basically most animals don't maintain elevated levels of stress, but humans, especially when they've experienced trauma, can experience elevated levels of stress for a very long period of time. People can also have a hyperactive amygdala, so their alarm system is always on, which can make it difficult to correctly interpret facial expressions and social cues or to sleep. So you might see someone who seems really jumpy or on edge, and that's usually a sign of a hyperactive amygdala. It can also result in hypersensitive acute stress response. So basically hyperactivation of the fight, flight, freeze, or fawn system. Emotionally, there are some risks associated with ACEs and trauma that can include depression, anxiety, irritability, fear, or negative self-related emotions. Those are usually more like a symptom of trauma as well. And then cognitively, there can be issues related to memory, emotional flooding, executive functioning, so things like planning or impulse control, attention, and intrusive thoughts. And again, I encourage you to think about, like, when have you seen these things in your clients? Like, for example, some case managers complain that their clients don't seem to be paying attention, or they seem to have trouble getting to appointments. And it's helpful to remember that that can be an effect of trauma or ACEs, somebody having difficulty with those things. We have a little diagram here showing the impact of trauma on our neurobiology that I just want to highlight. So when somebody experiences trauma, their brain adapts to its environment, especially when it's things like toxic stress or ACEs that are prolonged over a period of time. Certain pathways in the brain become ingrained, and what we call our window of tolerance decreases. Has anyone here heard of the window of tolerance? It's basically your window of emotional tolerance, like what you can tolerate. And when you go above it, you get activated. When you go out of it below, you get underactivated. With that, the amygdala grows, which can result in mood alterations, increased startle response, and a greater likelihood to perceive threat around you. That then causes the hippocampus shrinks, and it's harder to return to an emotional baseline. And it can be difficult to differentiate between past and present and interpret threats correctly. And then also the prefrontal cortex shrinks, which makes it difficult to control impulses and emotionally regulate and override your threat response. And this is like a mini cycle that happens over time with repeated exposure to stress or prolonged stress or trauma. And again, we just highlight this to note that, like, trauma affects the brain. And when people have a hard time coping with the world around them because of the trauma they experienced, it probably also has something to do with the fact that trauma impacted their brain in a negative way. That's not set in stone. The brain is malleable and adaptable throughout the lifespan. These things can change. But again, just reframing the what's wrong with you to what happened to you to understand when you might be seeing these things in your clients. We also want to talk just a little bit about the trauma response here. Like, when you think about all those things that happen in the brain, it can cause our fight, flight, freeze, or fawn system to be hyperactivated. And not all of these things will be happening all at once. People tend toward either fight or flight or freeze or fawn in different scenarios or different situations in their lives. But when somebody has experienced toxic stress or trauma and their brain perceives a threat, they might be more likely to react with one of these four responses. And we're not going to go through these in depth, but that's just something to keep in mind, that, like, maybe after today's training, you come back to these things and you ask yourself, what am I seeing this in my clients? Because it might help you understand that they're having a trauma response to a situation and it's not you, it's not like something they can necessarily control. It's probably has something to do with trauma they've experienced. Okay, the emotional impact of trauma. Adults who experience trauma in childhood often have different brain development than those who did not, as we talked about. So their brains, primed to deal with nearly constant stress, can struggle to respond appropriately to situations that would otherwise appear normal and non-threatening. So you might have a client who comes into a walk-in center and seems really on edge, or maybe blows up at somebody, to a situation that like you think like that didn't warrant that. And that is a trauma response when somebody does that typically. And this partly explains why many adult trauma survivors struggle with depression, anxiety, and other issues related to emotional regulation. It can be really hard to cope with the world around you when you're constantly on edge like that, and have basically unresolved trauma, or trauma that is affecting your brain and your emotions. These resulting mental health issues can contribute to long-term difficulties maintaining healthy relationships and lead to problems at school and work. So we can start to see that like outside of our neurobiology, trauma then has an impact on our ability to like function in society. So again, reframing like, gosh, my client like can't hold down a job or can't like engage in these relationships in healthy ways, to a more compassionate response of, they've probably been dealing with a lot of stuff and let's figure out how we can help them. Cognitively, trauma can make us feel like the world is an unsafe place to live in, that other people are unsafe and can't be trusted, that one's own thoughts and feelings are unsafe, and can cause us to anticipate crises, danger, and loss when they may not actually happen or even be likely to happen. And then some relational and spiritual risks that we already touched on a little bit are just difficulty trusting others and feeling love, some emotional distancing, or relationships that are characterized by anger and mistrust, and then feeling a little sense of purpose or meaning and feeling disconnected from the world. All of the risks associated with trauma and ACEs also impact people's relationships. And in the case of clients seeking services, this can impact their interactions with service providers and other clients in those settings. Regardless of the type of trauma a person has experienced, traumatic experiences do impact relationships between people, with communities, and with delivery systems that support people's health and social needs, like service providers or hospitals. When a person has experienced trauma, they may feel unsafe, betrayed, or have difficulty trusting others. This can lead to, as we discussed, heightened emotions like anger or aggression, a tendency toward shame, numbing, or isolation, and can negatively impact the bond between a client and their provider, and thus a client's engagement and care. So we often come across clients who are hesitant to engage with service providers or don't seek the care that they need that is available to them. And that is often because they've either had traumatic experience with those providers, or they've had other traumatic experiences that make them distrustful of those relationships. The good news is not everyone who experiences trauma, toxic stress, ACEs, or adversity experiences these risks associated with all of those things. People who do experience some of these risks do not typically experience all of them. So I just went through a lot of ways that trauma can impact us, and all of those things don't typically affect one person. It's usually a handful of things. And there are protective factors that can buffer against these risks. Protective factors can occur in the moment of risk and help to prevent negative outcomes. Protective factors can also be adopted later to help a person heal from trauma, as well as the negative impacts of trauma. So I know that I just painted a bleak picture of all of the impacts of trauma, but I do really want to highlight that it's not the be all end all for a person, and there are pathways to healing for people who have experienced trauma. Okay, so we're going to go into breakout rooms, and we're going to pause the recording when we do so that you all can talk freely. And I see a question in the chat. What does ACEs stand for? It's Adverse Childhood Experiences. Thanks for that question. So in the breakout rooms, we're going to talk about, like, did you know about all of these impacts of trauma? What was new information for you? How does this impact your view of clients, knowing that they've likely experienced trauma and some of its impacts? And all of the breakout room facilitators have the slides, so we can pull them back up for you if there's specific things that you want to talk about. Are the breakout rooms ready? All right, everybody is zoomed back in. Apologies for my dad joke puns. Looks like Janet will be reporting out from one of the breakout rooms. Do we have someone selected to report out from the other one?
I'll report out. Yep.
Okay. So yeah, I just wanted to take a couple minutes for folks to share generally what you talked about in your breakout room.
I can go first if y'all would like. We had a lot of experienced folks in our breakout room who have been doing this work for a while. We focused on the responses, the fight, flight, fawn responses. And we kind of talked through what it took to kind of identify those first. Some folks just have long-term experiences with clients and they recognize that people can shift in and out of the different responses, but that they have kind of an overall response sometimes that is one of those four. And we also talked about how we would kind of help folks through recognizing that while their brains may be temporarily wired in a certain way, there's things that we can do, like encouragement and acknowledgement and kind of some probing questions on how to deal with certain situations when they come up, as a way to work through that and work toward healing. And I think that's what we covered, but I welcome other folks in our group to respond also.
Thanks, Vanessa. Janet, would you like to share from the other group?
Yeah, I can go ahead and go. So we talked about how we are all familiar with the trauma-informed care, but because we've taken previous trainings, but it's really, really good to have the refresher just because it is constantly something that's in the background of our work. And so it's good to just be reminded of trauma-informed care. And it's just important to keep in mind the background of our clients, since so many of them have experienced trauma, and it's a good background to have. It's good knowledge to have about why certain clients react certain ways, and it may not be the way that we react, but again, their brain may be wired differently, and it's something for us to always keep the context in mind.
Great. Thank you, Janet. Appreciate that. Okay, well, I think next I'm going to hand it over to Nicole to walk us through some other parts of this training.
Thanks, Patricia. And we will take a moment just to let this next portion of the presentation be shared with you all. So while we're doing that, I always get excited about talking about trauma and homelessness, not because this is a fun topic, but because I worked as a clinical social worker for over a decade, managing shelters for folks experiencing trauma, experiencing homelessness. And I'll also share with you that I experienced chronic homelessness throughout childhood and early adult life. So though it's been 17 years since my last episode of homelessness, and an awful lot of balls would have to drop for me to experience that again, the impact of those experiences are still very present in each and every decision that I have ever made, both personally and professionally. And so I say that and I share that to give you an example of how those ACEs that Patricia talked about earlier stick with us and how they very clearly can change, brain patterns, including the way we interact with the world moving forward. We can go to the next slide, please. So I want to make sure that we all start this conversation with the understanding that an episode of homelessness all by itself is a traumatic event. And as we move throughout this discussion, I want to remind us to think about the different identities that we know statistically are most impacted by homelessness. And I'm specifically referencing Black, Brown, Indigenous, immigrant, and LGBTQ populations. These populations are experiencing various forms of trauma in addition to and often preceding their experiences with homelessness. We can go to the next slide, please. So trauma-informed care and service delivery may look like, from our perspective as providers, clients who are consistently dishonest, clients who don't ask for what they need or admit when they need help, clients who may blow up at the tiniest of things and their responses don't seem to match the situations, and even the clients who appear unable to solve very small problems or cope with the usual life stressors that adults may have. Using a trauma-informed care approach means that we as service providers recognize that all of our clients are responding to the impact of trauma in their lives. We can go to the next slide, please. So now we have a breakout room question. And for this question, you can go ahead and drop your response in the chat. How else might trauma impact the individuals and families that you might encounter specifically in encampment? So again, some examples might be a lack of trust in service providers. So the person that just won't engage, inappropriate responses, meaning that they might blow up at the smallest thing, difficulty asking for and accepting help. This is the person who won't tell you what they need or who won't take the help that they very clearly need. And sometimes difficulty sustaining long-term relationships. So again, go ahead and drop your answers in the chat. How else might trauma affect individuals and families that you might encounter specifically in encampments? I can think of a few that I've seen here in DC. For example, at some point, we had a very large encampment community downtown. And very often you would see people bring their lunch and want to go eat in the park where the encampment was located. And sometimes the people going to eat lunch would be upset by the people in the encampment who were living there because they're trying to eat lunch and it's, people living in tents. And sometimes the people living in the encampment would not accept food that somebody having lunch might offer. So say, for example, I might buy 2 lunches because I know I'm going there and there's somebody who needs food and somebody might ask me for some. So I might offer someone a sandwich. They might say no. They might angrily say no. They might yell and curse me out. Trauma-informed care means recognizing that it's not me. It's not a direct response to me. They are having a response to the trauma that they've experienced in their life. And I see some responses coming in, and these are great. Please keep them coming. Lack of self-worth or confidence, never feeling safe or secure, distrust of help, as well as distrust of other individuals experiencing homelessness. Thank you all. You can keep responding to that question if you like. And we are going to go to the next slide, please. So now we're going to talk about, basically the nuts and bolts of trauma-informed care. We can go to the next slide. So trauma-informed care basically means that we are creating an environment that responds to clients under the assumption that they have experienced trauma. And there are a few core principles. So trauma-informed care is all about understanding trauma, right? By knowing and understanding trauma and stress and how it impacts people, we can act with compassion and take well-informed steps as we're interacting with people. Safety and security, by increasing stability in our daily lives and having core physical, emotional safety needs met, we minimize our stress reactions. And that's true for the people that we're working with. Cultural humility and responsiveness just means that we are open to understanding cultural differences and responding to them in a sensitive way. Compassion and dependability means that when we experience compassionate and dependable relationships, we are reestablishing trusting connections with others And collaboration and empowerment means that when we're prepared for and given real opportunities to make choices for our own self-care, we feel empowered and can promote our own wellness. And resilience and recovery just means that when we focus on our strengths and clear steps we can take toward wellness, we're more likely to be resilient and recover. Essentially, using a trauma-informed care approach helps the person who has experienced trauma. It helps us, again, move from what's wrong with you to what happened to you, and we focus on the whole person, including their experiences before we ever came into contact with them. We can go to the next slide, please. Now, how do we actually incorporate all of this in practice? We, as providers, we get these trainings with all this good information so often, but how do we actually do it in the day-to-day, right? When it comes to service delivery, we just want to recognize that everyone has experienced trauma and let that influence how we move about our day and do our work. So again, we're assuming that everyone has experienced trauma. We are making sure that we realize, recognize, and respond. So we're not assuming that someone's trauma has impacted them. We don't need to analyze or call out the trauma. Trauma-informed care just means that we're creating the environment and responding to clients under the assumption that they've experienced the trauma. So for example, we're not saying, oh, Michael, I see you're having a hard time trusting me, so you're not engagement. This is very clearly a trauma response. No, trauma-informed care is more of an internal thought. It's thinking to yourself as the provider, Michael's not engaging with me. Maybe there's some trauma that's causing this response. Perhaps I can change my approach and give him a little more time before I close out this case for lack of engagement. So that's the response. By fully integrating our knowledge about trauma into policies and procedures and practices, we can actively resist re-traumatization and hopefully get people connected with the services and the help that they need. We can go to the next slide, please. So I love this graphic because it gives me a little bit of help in remembering the principles on a very real and practical level. So for example, for safety, we have the definition, ensuring physical and emotional safety. And the principle that goes along that, common areas are welcoming and privacy is respected. Super simple, something that we can implement in our offices, out in the field, just in our day-to-day interactions. It gives you an example of how incorporating these principles can be applied on a very basic level. We can go to the next slide, please. So now we're going to do another breakout room activity, and we're going to go back to those 6 core principles of trauma-informed care. And we're going to talk about how we use the principles, how we think we could use these principles within our work in the encampments, and what practices are currently happening with your interactions that might not go along with a trauma-informed care approach, and what shifts can be implemented to turn this around. So again, you're going to click when that breakout room opens and go ahead and discuss, and then we'll come back and share out. Thanks, Maddie. Welcome back, everyone. And do we have someone from each group to give us a little report from your breakout room?
First for our group. We talked a little bit about the different principles, and with safety, we started with how we make sure to go to the encampment as a team or to go with partner agencies to ensure that their safety and the safety of the client is kept in mind. They really have a strong focus on choice, where ensuring that even in the spaces of the talk with the client has a choice to be around people, or maybe getting a quiet space, or making sure that they're comfortable, sharing what they're sharing in the spaces that they're in. Also, making sure that they understand the details of the program that they're involved in, that they have multiple opportunities to ask questions, to be able to understand the details of the program they're enrolling in, and ensuring that they're able to come into this program feeling that this was their decision and not that they were not forced to join anything. And that kind of also led to conversations around collaboration, in which we try to make sure that the client doesn't feel like they're walking away with a longer list of like assigned tasks, but rather there is a collaborative discussion about what the client needs are and what they anticipate the next steps are to meet those needs and how they can be best supported to take those steps. And finally, we had a great discussion about cultural sensitivity and how people from different backgrounds and cultures can internalize things differently and according to their own value and belief systems. And that can also lead to how people trust and how people communicate and the things that, you know, might be important to them or not be important to them. So that is kind of like the overarching discussion we had across the board.
Thanks, Sarah. So I heard a little bit of background noise, so I'm going to recap in case anyone else didn't hear. You also talked about safety of the client and workers kept in mind when folks are going out into the encampment, the importance of client choice. For examples, we're needing to be in a quiet space or separate from others to support like confidentiality, opportunities for clients to ask questions when they're coming into the program so that clients can feel like it was their decision, and a lot of collaboration about like letting the client lead the service delivery to share what they want instead of them walking away with like a huge task list and maybe feeling overwhelmed. And the importance of cultural sensitivity and how perception based on different values and beliefs might impact service delivery. Thanks, y'all. So other group ready to share out?
Annie, do you want to share or would you like me to? We got cut off right after.
Yeah, no, I can do that. One thing that we talked about was choices. It's important for people to feel what I call idea ownership. They have to take ownership of what they're working on. It's really important that people understand that they have options and that they're not just being told what to do. I think it's important for people. One of the things we talked about was clarity of what helping roles people are fulfilling, and there needs to be some flexibility in that, whether a person is helping with someone with housing or case management. Sometimes people get confused about what role is what, and it's important that people feel like everybody is a team player and that they're not being passed off like a football. Cultural sensitivity, I just want to say the important thing about cultural sensitivity, and this is my own personal take, you need to treat everybody like they're your daughter or your son or your cousin or your niece or your nephew, somebody that you can relate them to. And then you're going to treat them exactly the way you would treat your own family.
Thanks for sharing that, Annie. Before we move forward, just again, if we have any questions, feel free to drop them in the chat or raise a hand. Let us know that you have a question. I know we're covering a lot of information in a condensed time period. All right, we can go ahead and cue back up the slides and we'll keep moving. We can go to the next. Thanks. All right, so now we're going to discuss using, sorry, there's one more slide before that, Vanessa. The outcomes of trauma-informed care. So there are a number of outcomes for trauma-informed care. A lot of these have been, at this point, supported by data, and we know that there are significantly better outcomes for adults and children. Using a trauma-informed care approach has a positive effect on housing stability, meaning that people are able to stay safely and securely housed longer when a trauma-informed care approach is used in service delivery. There's also a decrease in crisis-based services. It is cost-effective. There are positive responses from providers and positive responses from consumers. So on both ends here, trauma-informed care is working and it helps everybody, the service providers and the clients. We can go to the next slide, please. All right, so now we're going to dive into trauma-informed care, specifically within organizations. So we can go to the next slide. And we're doing this because adopting a trauma-informed care approach isn't just accomplished by like any one singular technique or checklist. It's not something that each individual service provider, case manager, or person who's gone out into the field can do this on their own. It requires constant attention, caring, awareness, sensitivity, and even possibly a cultural change all the way up at the organizational level. And also ongoing internal organizational assessment and quality improvement, as well as engagement with different community members, will help to embed a trauma-informed care approach. So some examples or things that we might see in an organization that's lacking trauma sensitivity: large displays of power, high staff turnover rate, low staff morale. Consumers they're not empowered, they're feeling devalued, and problem focused versus solution focused things are happening. So if you can kind of compare this to some of those trauma-informed care principles, it's like literally the complete opposite. We can go to the next slide, please. All right, so trauma-informed services. Again, we are creating responsive services and programs. We're avoiding re-traumatizing clients, and we're helping clients with that need. It kind of all flows through together. So when we understand, anticipate, and respond to the issues, expectations, and special needs of each and every person, at a minimum, we're able to kind of break through and we're able to help them in some way, shape, or form. We can go to the next slide, please. So again, this is just a graphic comparing some of the differences between trauma-informed services and a more traditional approach that wouldn't take into account someone's experiences with trauma. So for example, a trauma-informed care approach would say that problems or symptoms are interrelated responses to or coping mechanisms to deal with trauma. So again, taking the example of the person who apparently seems to not want to take any help. The traditional approach would say that this problem is separate. It has nothing to do with their trauma. They just don't want to participate in these services, so they must not, need or want our help. Another example, because I heard it mentioned in the groups quite a bit, understanding that providing choice, autonomy, and control is central to healing. That's a trauma-informed approach. The opposite, or the traditional approach that doesn't incorporate a trauma-informed care, is going to see clients as broken and vulnerable, and they need to be protected. That's that sense of service providers kind of taking charge, kind of like as a parental figure, thinking that clients, they can't make informed choices. They can't take care of themselves. They need us to step in and protect them. That is not a trauma-informed care approach. We can go to the next slide, please. So this graphic gives us an example that an organization can go through in terms of completing a self-assessment. So to assess trauma understanding, we can ask, does the organization or the staff itself understand trauma? So that's all that really great information that Patricia shared with us earlier, the very basics of trauma, how it impacts the brain and the body and ACEs and all of that. For safety and security, we can ask, does the organization promote client safety? For cultural humility and responsiveness, is staff open to understanding cultural differences? Do they respond to them sensitively? For compassion and dependability, are staff practicing compassion? Are relationships between clients and staff dependable? And are staff dependable with each other? For collaboration, do staff collaborate and empower each other? Do staff maximize opportunities to collaborate with clients and share power in decision-making? And then for resilience and recovery, is there a strengths-based focus when working with clients and each other? What I want to point out here is that there are a lot of questions that are targeting the staff within the organization completely separate from the client. And that's not by accident, right? That's because in order to really consider the whole person and look at things from a trauma-informed care approach, we've got to be thinking about the policies and practices that we implement on an organizational level. Going back to my example about, not automatically terminating the client who seems to be not engaging because we recognize that there might be a trauma response going on there. So maybe the policy looks like we give a little bit more grace. So maybe it's not just 3 calls and we never reach out again. Maybe it's 3 calls and a visit. You know, maybe it is 3 calls and a visit, and we extend some other form of communication to see if they take it in that way. But it's all about the organization and the individual people who are on the ground working, doing this work, and kind of bringing everything together. We can go to the next slide, please. So again, we are moving away from a problem-focused approach to strength-based thinking. So the traditional might say, they should be over this thing that happened to them when they were a kid. You know, they're 40 years old. Trauma-informed care would say recovery from trauma is a process and it's going to take some time. You know, a traditional approach might say, you know, don't ask this person about this thing because they're going to get upset. A trauma-informed approach would say, talking about the trauma gives people permission to heal. It would also look into the fact that, you know, getting upset is okay. You know, that's a natural, normal response, and it's okay to get upset. We give them permission to get upset because we know as trauma-informed care providers that this is a part of their healing process and it's ultimately going to help. We can go to the next slide, please. So some employee considerations to think about. When an organization that practices trauma-informed care needs to be aware of the secondary traumatic stress or vicarious trauma for its employees. So this is something that can happen when individuals have chronic exposure to traumatic materials. So for example, I think about when I was a social worker and I might have had 40 people total on my caseload. And every single one of those people is experiencing a traumatic event. And I am tasked with making sure they get housed. And so if I take a sick day, that means that somebody's not getting the service that they need. But it also means that I might make the decision not to take the sick day that I need because I am so focused on my clients that I'm not taking care of myself. So organizations have a responsibility to provide an outlet or some way for employees to get self-care. And that could look like regular supervision, training, mental health benefits, a variety in job duties, and a non-toxic workplace. Of course, we know that these aren't all things that every organization can do because these things cost money, but these are definitely considerations to think about when we're moving forward and we talk about implementing trauma-informed care at an organizational level. Another note, trauma-informed care is not a one and done training based on evidence-based interventions. It's an ongoing journey and it has a much larger systemic impact that again requires change in the organization structure to benefit both the folks that we're serving and the practitioners. We can go to the next slide, please. So some guidelines for working with people affected by trauma, which means everybody. We use a strength-based perspective. We think about understanding how to talk with people who have experienced trauma. We take into account cultural language and assumptions about considerations, and we know how to ask about traumatic experiences. Some things to watch out for that might be negatively impacting staff: burnout, empathy fatigue, secondary trauma, trauma exposure responses, and all of the risk factors to everything we've discussed. We can go to the next slide, please. So now we have another breakout room conversation. And for this one, we're going to do it a little bit differently. We're going to go to our breakout rooms. You're going to get scenarios and you're going to talk through these different scenarios amongst yourselves and with your leaders. And then we're going to come back and report back again. And again, if you have any questions, feel free to drop them in the chat and just let us know. Welcome back, everyone. I hope you all had a great conversation. Now, again, we're going to have someone from each group go ahead and report out with those big 3 takeaways. I think David is one person reporting out.
Okay, so is there anything that you wanted to, in particular, that you were looking for?
I'm sorry, your big three takeaways about the principles of trauma-informed care, everything we learned today.
So we talked about going out to encampments and being prepared physically, emotionally. So one of our agency rules is we generally don't go out to encampments unless we have a partner with us, a coworker, someone like that, or someone from another agency who has experience working with this client in the community. So we do that. We try to be prepared with a positive and open attitude. We try to have resources available so that in case they do ask questions, that we can give them specific answers in the moment instead of having to tell them, oh, well, we'll have to get back to you. So what we try to do is build rapport in the community with some concrete answers if possible when we're there. And just try to act like we're in their home, which we actually are. I also, one of the things I do is if they have friends around them, I introduce myself to their friends, generally talk to them, ask how things are going in the moment. So just try to be with them. And I kind of joke, because actually the first time I went out there, one of the guys had a friend that showed up with a bottle of booze and asked me if I wanted to join them for a party. And so I politely declined and just, asked them what I could do to help them out. But yeah, that's kind of how we try to approach going out to an encampment.
Thanks, David. Do we have the next group ready to share out?
Yeah, I can share for our group. Apologies for the loud background noise if it's disruptive. But our group takeaways were also, a lot of focus on preparedness and what that could look like, having answers to some of the common questions ready, and really working with the community and treating the encampment as one big community, because the clients usually do, and having a lot of resources ready to kind of speak to the community care. So we talked about, especially when medical care is needed, creating a plan with a friend they might have, or a family member they might have, and or somebody who they can contact through the phone, or somebody they can get a ride with. So just helping them plan for themselves to the resources that they would feel comfortable with was a big part of the conversation. We also talked about resources, ones that are commonly available, and some resources that are in the pathways of kind of trying to think outside the box a little bit to respond to people's needs. So one of the concerns that came up was like places where people can store their things when they need medical care, or they need to go out for appointments. Concerns that clients often have about pets and where they can leave them. So, we talked about ideas of programs having a mobile pet holding station, or, programs thinking about expanding the capacity to be able to support those needs. We also talked a little bit about, having a sense of acknowledgement, where we can acknowledge that the client's past experiences with other agencies or programs might not have been too great, and acknowledging their frustrations and experiences they've had so far, and making them feel heard and making them feel seen in what they've experienced can really go a long way. Asking them a lot of questions, asking them, how they're feeling in the moment, can help them understand that they they're cared for, that people care about their mental well-being, and then connecting them to resources like, helplines at the trust line, giving them contacts, non-emergency numbers, doing wellness checks, are all other ideas that came up. We also talked a little bit about common things that can be challenges. So one of the things that came up was, people often have challenges with like medical bills and how they can impede their access to housing. So just kind of keeping in mind the general the broad scope of issues that our clients face on the daily, and keeping in mind that how those things can intersect with each other, and showing up to provide answers to the best of their ability was the general discussion.
Thanks, Sarah. It sounds like you all had amazing discussions, really starting to kind of put those principles in action. And we are really grateful that you were so engaged and willing to participate with us today. And that brings me to our final point, which basically is just that trauma-informed care essentially moves us away from the disease model of helping folks to a strengths, resiliency, and wellness model. And the whole purpose is just to connect life events to current levels of functioning. And this reframe essentially opens up a whole new world for us as service providers, the people that we serve, and then our staff within our organizations. It helps to change internal messages around perceived weaknesses and deficits. So it takes us away from someone as being broken or weak to someone is a survivor, someone is thriving, someone is very strong, which to the people we are served says that you can overcome this just as you have overcome and survived all these other things that have happened to you in your life. So thank you again for joining us. And now we have a few notes to go ahead and share, unless you have any questions about trauma-informed care. So that could be questions about trauma in general, questions about applying a trauma-informed care approach, questions about those core principles. Any questions about today, you can go ahead and unmute yourself and ask them, or you can put them in the chat. All right, if we don't have any questions, we will keep on moving. So one announcement, we have a satisfaction survey, and the results of the survey are going to be shared with home-based TAC, Cal ICH staff to improve future technical assistance. All the questions are optional, and if you have any questions, you can reach out to erf@homebasedccc.org. The link to the survey is in the chat now. You can go ahead and click that. We also have some upcoming trainings that are related to trauma-informed care. So one is motivational interviewing. This training is going to be July 12th at 9 a.m. Pacific Standard Time. You can register with the link that's in the chat. Also, motivational interviewing is a trauma-informed approach to conversation. It focuses on partnership, acceptance, compassion, and education. At this training, participants are going to learn the principles of motivational interviewing, practice motivational interviewing techniques to resolve ambivalence and promote change, and engage in scenario-based exercises and role play. So it's going to be really interactive. It's not going to be just someone sitting and talking at you for a couple of hours. It's going to be something that you can really take and put into practice pretty quickly. The next training is going to be focusing on empathy, fatigue, and burnout. And that training will be July 20th at 10 a.m. Pacific Standard Time. Registration is going to come out in the ERF newsletter. So the empathy, fatigue, and burnout training is focusing on these three issues because they're widespread across homeless systems of care staff, particularly frontline staff, so folks who are out there in the field. And this training aims to define empathy, fatigue, burnout, and other related terms. It's going to explain what contributes to empathy and burnout across staff, discuss how organizations can help to prevent burnout and address it among staff, and discuss how organizations can support a resilient workforce. So again, that training is July 20th at 10 a.m. Pacific Standard Time, and registration is going to be announced in the ERF newsletter. Both of those trainings are going to be recorded and advertised again in next month's newsletter. And the link to register to receive that newsletter is also in the chat. So again, links that are in the chat, the training satisfaction survey for today's survey, the July 12th motivational interviewing survey, and the ERF newsletter sign up link are all in the chat. So you can go ahead and click those and make sure you get connected to everything. And then there were a couple of questions about today's training and how to access that recording. And I'm going to let Maddie go ahead and let you know that information now.
Yeah, so we've been recording today's training. We also have our slides that were chock full of good information. So we'll be sending out an email to everyone who registered for today's training with that information here shortly. So look out in your inbox for the slides and the recording.
Thanks, Maddie. And that concludes our training for today. Again, if you have any questions, come off mute, ask us those questions or drop it in the chat. We'll give it a few minutes so that we can make sure everybody gets those links. You're all done. You can go ahead and leave and get a few minutes of your time back. Thank you all again.